Let's continue. So I'll finish off labor, I'll do prepurum, and I'll study till 3:30 in the morning. After that I'll just go to sleep and I'll wake up and I'll do some more topic like heart and diabetes and stuff like that. Okay. So preparation of delivery, you have position lateral squatting, position of partial sitting, dorsiflex position with 15-degree left lateral tilt. Commonly found as it avoids arthrocable compression and facilitates pushing effort. So clean aseptic procedure you have to maintain. Clean hands, clean surface, clean cord cut, clean stump. Some other things are clean. Then delivery of head. Flexion of head is maintained. Small suboccipital diameter less than 10. Suboccipital frontal diameter which is 10 cm descends through the valvular outlet instead of a larger occipital frontal diameter. Suboccipital suboccipitofrontal. Okay. Then Ritten's maneuver is slowly delivery of head in between contraction accompanied by pushing the chin upwards with right hand. Left hand exerts upward pressure on the occiput. So force mouth and it's born successfully overstretched perineum by extension. Ritten's method is also what do you say? Delivery by extension. Then crowning of the head, maximal diameter of the head by parietal diameter stretches the vulvar outlet without any recession on the head even after the contraction is over. So yeah, biparietal diameter will stretch the vulvar outlet. So delivery of shoulder, head is grasped, then gently drawn posteriorly until the anterior shoulder is released. Then drawing the head upward in upward direction, the posterior shoulder is delivered out of perineum. Traction on the head should be given gentle to avoid brachial plexus injury, hematoma of the neck, fracture of clavicle. Fracture of clavicle is one of the more common complications. Fracture of clavicle and Erb's palsy. Brachial plexus injury, hematoma of the neck, fracture of clavicle. Then delivery of the trunk, 4 fingers of each hand and are inserted inside the axilla. Then trunk is delivered gently by lateral flexion. You provide flexion laterally. Then management of third stage, you have expectant manager and active management. Active management, you provide 10 units intramuscular, which is preferred, or injection methagreen, oxytocin 10 units intramuscular, methergine 0.2 mg intramuscular to the mother within 1 minute of delivery of the baby. Within 1 minute, 0.2 mg methergine and oxytocin 10 units intramuscularly. Then clamp, divide and ligate the cord. Then deliver the placenta by controlled contraction soon after the delivery of the baby. Then if that fails, repeat after 2 to 3 minutes. If it still fails, wait for 10 minutes, repeat. If it still waits, you have to do manual removal, which is oxytocin, methergine you have to provide, examine the placenta and membrane and inspect vulva and perineum. Okay. Then expectant is delivery of the baby, called clamp, ligate the cord, watch and wait and watch. Cauterize the bladder if needed, guard the fundus, wait for spontaneous separation of placenta. If placenta separates, wait for spontaneous expulsion with aid of gravity. If that fails, you have to provide assisted expulsion. Then you have to give oxytocin 5 to 10 units slowly, IV or IM, and examine the placental membrane and inspect the vagina and perineum. Ischial spine importance, so it has advantage. So head is descent is examined in relation to ischial spine. It is better than station of the head in relation to ischial spines. Excludes the variability due to caput and molding. Assessment is quantitative, easily reproduced, and vaginal examination is to be avoided. Generally in pregnancy you shouldn't do vaginal examination. Then immediate care of the newborn, place him on a tray, head till down 15 degrees, facilitates mucous drainage. From mucous drainage you have to do tray at lower level than uterus to facilitate gravitation of blood from placenta to the infant. You have to do. Then air passage, oropharynx cleared of mucus and liquor by suction. Apgar rating at 1 minute and 5 minutes to be recorded. Clamping and ligature of cord to be done. 2 courses for forceps you need to do. Near 5 cm away from the umbilicus. It is to prevent soiling of bed with the blood. Prevent fetal blood loss of a second baby in undiagnosed monozygotic twin. Then second cord is placed between two clamps. Two separate cord ligature are done using reef knot. Squeeze the cord prior to clamping. Prevent accidental inclusion of embryonic remnants. Abnormality in the cord vessels. Single umbilical artery is to be noted. Cut 10 days with sterile gauze piece. You have to cover it. Then delay clamping. Transfer few amount of blood. Beneficial to mature baby, and it is like deleterious to premature or low birth baby due to like you need it for low birth baby and hyperbilirubinemia. If it is hypovolemia, hypobilirubinemia, you might be a problem. Then condition of early cord clamping. If it is a preterm or what do you say? Like hypervolemia and hyperbilirubinemia occurs, so you do not do early cord clamping with preterm growth restricted, like risk of hypovolemia leading to congestive heart failure is there. Then birth asphyxia is immediate resuscitation of the baby is priority. RH ISO immunization you have to do. HIV positive patients you have to check, and maternal diabetes you have to check. And 1 second. Thank you. Just a second. And so assisted expulsion is controlled contraction, modified Bernd-Anderson's method, where palmar surface of the left hand is approximately placed at the upper and lower uterine segment junction. It is placed here. Then body of the uterus pushed upward and backward. Right hand steady tension is given in downward and backward direction, holding the clamp until the placenta comes out. Lower uterine segment. Before the onset of labor, there is no complete anatomical division of uterus. During demarcation, active upper segment and relatively passive lower segment is more pronounced. Wall of the upper segment becomes progressively thickened. Wall of lower segment becomes progressively thin. It is pronounced in late stage 1 after rupture of membranes, becomes prominent in late stage 2. Then physiological retraction ring. It is a ridge produced at the junction of the two segment. This is physiological retraction ring. Should not be confused with the pathological retraction ring, which is obstructed labor significance. Clinical significance: implantation of placenta in lower segment is known as placenta previa. Through this segment, that cesarean section is performed, and implantation of placenta in lower segment is called as placenta previa. Through this segment, and that cesarean section is present. Site of rupture in obstetric labor. It is a site of rupture in obstetric labor. Okay. Normal prepurum. We go on to normal prepurum. Lactation is a secretion of mammary gland after delivery is colostrum. Colostrum contains high protein, less fat, less carbohydrate, vitamin A, sodium and chloride, and IgA antibody. Because less fat has a laxative action, you need less fats. Then mammogenesis is physiology. Mammogenesis you have first of all under influence of estrogen, progesterone, and prolactin in pregnancy. Lactogenesis is alveolar cell are the principal sites for production of milk. Alveolar cell. 3 days postpartum, colostrum is secreted exclusively. Milk secretion starts on the 3rd or 4th postpartum day. Then estrogen antagonizes positive effect of prolactin on milk production. Expulsion of placenta will lead to drop in estrogens and progesterone. It initiates milk production. Then galactokinesis is sucking or milk ejection. Milk let down reflex. It is a tactile impulse from nipple and areola pass via the thoracic sensory 4, 5 and 6 neural arc. So paraventricular and supraoptic nuclei of hypothalamus it will involve. Okay, so it synthesizes and transports the oxytocin to the posterior pituitary. Okay, so first of all, tactile impulse from nipple and area pass through the sensory thoracic sensory, which is T4, T5 and T6, and neural arc leading to paraventricular suboptic nuclei of hypothalamus. Then there is synthesis and transport of oxytocin to the posterior pituitary. There is release from posterior pituitary to which causes oxytocin contraction of smooth muscle in the duct of ejected milk. Galactoporosis, you have prolactin causes production of milk. Other contributing factors, you have insulin, glucocorticoids and growth hormone. Okay, then milk production, you have 500 to 800 ml of milk per day to feed, requires about 700 kcal per day for mother. Inadequate lactational failure, you have due to infrequent suckling, due to exogenous suppression of prolactin, and pain and anxiety and insecurity. Argot, pyridoxine, diuretics retained placental bits, etc. Drugs to improve milk production, galactagogues is metoclopramide, which is 10 mg TID, increases milk volume 60 to 100% by increasing prolactin levels. You have sulpiride, which is a dopamine agonist. Domperidone has also been found effective. Intranasal oxytocin contracts the myoepithelial cell and causes milk letdown. Then lactation suppression needed for women who cannot breastfeed. Baby is born dead, baby dies in neonatal period, and breastfeeding is contraindicated. Stop the breastfeeding, avoid breast milk pumping or milk expression, wear breast support, ice pads to prevent engorgement, analgesics and tight compression bandages for 2 to 3 days. Natural inhibition of prolactin secretion will result in breast involution. Medical methods include estrogen, androgen, or bromocriptine is not advised. Only mechanical like diet methods, all these methods are better. Drugs to improve is metoclopramide, which is sulpiride. Metoclopramide increases the prolactin level. Okay. Domperidone increases also domperidone. Okay. Intranasal oxytocin contracts the myoepithelial cells, and you provide just oxytocin intranasally, and you will let down, milk letdown will occur. Normal prepurum, there is following childbirth, involution of body to pre-pregnant state autonomically and physiologically. Woman is termed as purpura, begins as soon as placenta is expelled and lasts for approximately 6 weeks. Period is divided into immediate, early and remote. Less than 24, 7 days, 6 weeks. Then similar changes occurs following abortion, but takes a shorter period. Okay, involution of the uterus becomes firm and retractile with alternative hardening and softening. By 6 weeks of prepurum, uterus involutes from 1000 grams to 60 grams. Flabby collapsed lower uterine segment involutes in a few days. Contour of cervix begins in 6 weeks. External loss never reverts to nulliparous state. Physiological, there is number of muscle fibers not increased, reduction of myoepithelial cell size, efficiency of enzymatic action will be there, relative anoxia induced by effective contraction and retraction of uterus. Endometrial regenerates within 16 days of prepurum, except at placental site where it takes about 6 weeks. So clinical assessment, you have bowel and bladder emptied beforehand. Following delivery, fundus lies 13.5 cm above the symphysis pubis. Steady decrease in height by 1.25 cm per day. By the end of second week, uterus becomes pelvic organ. Second week, it becomes pelvic organ. Okay. Involution of vagina, 6 to 10 weeks to involute. Regains its tone, but never to virgin state. Never it will become virgin state. Okay. Rugae is partially reappear at third week. Introitus remains permanently larger than the virgin state. Hymen is lacerated, represented by nodular tag like parenculate myritic forms. Lochia is superficial layers of superficial layers of endometrial decidua shed through vagina during first 3 postpartum weeks. peculiar offensive fishy smell will be there. Depending upon the variations of color of discharge, you have lochia rubra 1 to 14 days, blood, shreds of fetal membranes, decidua, vernix caseosa, and lanugo mecorium. All of them are rubra, lochia rubra. Lochia serosa is less RBC but more leukocytes. Wound exudate, mucus from cervix. Microorganism all cause lochia serosa, which is yellowish pink. Lochia alba, which is white, is seen in 10 to 15 days. Decidual cells are the leukocytes, mucus, collagen crystals, fatty granulosa, epithelium, microorganisms. Okay. More leukocytes, wound exudate, mucus from cervix. Decidual cells, leukocytes, mucus, collagen crystal, fatty and granular epithelial cells, and microorganisms. Then we have vomiting in pregnancy. Hyperemesis gravidarum is a common characteristic, common complication of pregnancy. It is a spectrum characterized by severe nausea, intractable vomiting sufficient to interfere with nutrition and activities. Then it is seen in maternal age more than. Risk factors is more than 35 years old, high body weight, nulliparous, H mole, cigarette smoking, twin pregnancy, fetal loss, and hyperthyroidism. Etiologically, you have hormonal causes, physiogenic causes, dietary deficiency, allergic or immunological basis, and decreased gastric motility. All of these will cause this hyperemesis gravidarum. Hormonal, you have thyroxine, you have prolactin, leptin, adrenocorticoid hormones, you have HCG, estrogen, progesterone. All of these hormones are influencing the hyperemesis gravidarum. Thyroxine, prolactin, leptin, adrenocorticoid hormones, HCG, estrogen, progesterone. Psychogenic, you have conversion disorder will be there, somatization will be there. Dietary deficiency, you have low carbohydrate reserve and deficiency of vitamin B6 and B1. B6, B1, low carbohydrate deficiency, conversion disorder, somatization. Then allergic or immunological basis also may be there, and decreased gastric motility. Most commonly it is hormonal. Thyroxine, beta, HCG, STG, progesterone, and estrogen. This is most common. So clinical feature: weight loss will be there, dehydration will be there, ketoacidosis will be there, hypocalcemic alkalosis will be there, thiamine deficiency which will lead to Wernicke's encephalopathy, vitamin K deficiency will be there, zinc plasma levels will be increased, and copper levels will be decreased. Plasma. Then indication for therapeutic termination in hyperemesis gravidarum: steady deterioration in spite of therapy, rising pulse more than 100 ml, temperature constantly more than 38 degrees, gradually increasing oliguria and proteinuria, appearance of jaundice, appearance of neurological complications. Jaundice if it's there, neurological complication, oliguria, proteinuria, temperature very high, rising pulse, steady deterioration in spite of treatment, in spite of therapeutic. So complication you have when Wernicke's encephalopathy, pontine myelinolytis, peripheral neuritis, cough, psychosis, stress ulcers, Mallory-Weiss syndrome, because they're vomiting all the time. If they try to hold the vomit, Mallory-Weiss esophageal tear will occur. Convulsions and coma, hypoprothrombinemia due to vitamin K deficiency, renal failure, and intrauterine growth restriction because of repeated abdominal trauma and stuff like that. Then investigations: urine analysis, serum electrolyte analysis, thyroid function test, and ECG. Those are the 4 investigations that you do. So management: you have to, total amount of fluid is approximated, you have to provide IV fluids, total amount approximately 3 liters. Half is 5% dextrose, half is ringer lactate. So principles of management: you maintain hydration, you control the vomiting, you control correct fluid and electrolyte imbalance, and you control metabolic disturbances, and you prevent serious complications. So anti-emetic drugs, you have promethazine, chlorpyrrazine, trifluoromazine, and metoclopramide. Then you can give hydrocortisone 100 mg IV, and nutritional supplementation, you have vitamin B1, B6, vitamin C, and vitamin B12. B1, B6, B12, C. High premises progressive chart is helpful to assess the prognosis progress of patient in hospital. Clinical features of improvements are evidenced by there is subsidence of vomiting, there is feeling of hunger, there is better look, there is normal pulse, blood pressure, and normal fetal growth on follow-up. Okay, those are all in thing. Then I'll come back to average in pregnancy, because they're all topics which I am very much familiar with, so I don't want to waste time. I feel I'll come back if I'm free, but yeah, these are all very easy, but I just need to do few rounds. Ectopic pregnancy also I know very well. Hydrated vesicular mole also I need to do. No, it's okay, I know somewhat. Multiple pregnancies, I'll come back. Polyhydramnios did somewhat recently, I'll come back. Preeclampsia, eclampsia, hypertensive disorder. Okay. Placenta succinata, I'll just do this once. It is one or more small lobules of placenta, size of a cotyledon at varying distances from main placental margin. Leash of vessel connecting the main placenta to small lobule will be transverse. Accessory lobe is developed. Activated villi will be there on chorionic leaf. So, in cases of absence of communicating blood vessels, it is called placenta sporia. Diagnosis is made following inspection of placenta after expulsion. Like one or more small lobes of the placenta, size of the cotyledon, and varying distance from male placenta is called succinata. Battledore placenta is also there. Maybe outside I forget. So different types of placenta. I need to just once again. Types of abnormal placenta. Okay. So, clinical significance: retained succinate lobe may lead to postpartum hemorrhage, subinvolution, uterine sepsis, and polyp formation. Treatment is expulsion of uterus and removal of accessory lobe under general anesthesia. Placental exochorialis is extrachorialis is also explained. Okay. Hypertensive disorders in pregnancy, preeclampsia. I'll read this later. I need to come back to this, all of this. Eclampsia, preeclampsia, anticonvulsant therapy, HELP syndrome, yeah. Placenta previa also, I need to come back. Abruption placenta also, I'll come back. Then surgical illness complicating pregnancy. 1 second. What's happening? All of these topics are very much important, but I'm not going to do them right now. These are also very much important. I'm thinking I'll do these things in tomorrow. This is very small. I think I'll do this today, and I'll do this today, I'll do this today, and tomorrow morning I'll wake up, I'll do like, so this is what, 30 pages here, and 109 to another 20 pages here. Those things I'll do off tomorrow morning, but for the time being I'll do from, I'll involve this also. and I'll do all this. Whichever I have been putting in the brackets, I'll do off right now. Hypertension itself will take some time. So okay, page number 65, 70 to 107, 70 to 107 plus 130 to 145. I'll do after that. Okay, let's go. Okay. Mm-hmm. Vitamin liver, iodine, and death. Okay. The faster I do this, the better. I'll finish this chapter. I will stop the stream for some time. So, surgical, and medical illness complicating pregnancy, anemia during pregnancy, hemoglobin less than 11 grams, and hematocrit less than 33%. CDC is cutoff point is 11 grams in first and third trimester, 0.5 grams in second trimester. So, severity of anemia, ICMR grading, 11 to 10 is mild, 7 to 10 is moderate, less than 7 is severe, and less than 4 is very severe. Okay. Yeah. Tier 1 11, tier 2 10.5, tier 3 11. Okay. Physiological classification of anemia. Physiological anemia pregnancy will be there. Pathological, you have deficiency anemia, iron deficiency, folic acid deficiency, vitamin B12 deficiency, and protein deficiency. Hemorrhagic, you have acute and chronic. For acute is following bleeding in early months or antepartum hemorrhage, and chronic is hookworm infestation and bleeding piles. Hereditary, you have thalassemia, sickle cell hemoglobinopathies, and hereditary hemolytic anemia, which is spherocytosis. Then bone marrow infiltration can be there. Hypoplasia or aplasia due to radiation, aspirin, indomethacin. Then anemia of infection, you have malaria, tuberculosis, and Kala Azar. Chronic renal disease may be there. Hematological malignancy like leukemias and lymphomas can also be there. Physiological anemia during pregnancy is increase in plasma volume 30 to 40%. Increase in red cell mass 10 to 15% during pregnancy is normal. There is hemodilution and apparent increase in hemoglobin level. Hemodilution during pregnancies reduces maternal viscosity, enhances placental perfusion, and facilitates the nutrient and oxygen delivery to the fetus. So physiological anemia starts at 7th to 8th week, maximum by 12th week, does not go below 11 gram percentage in first trimester and then in second and third. Then complications, you have maternal, you have preeclampsia, infection, heart failure, postpartum hemorrhage, shock, and pulmonary embolism during prepurum. Fetal, you have low birth weight, intrauterine death. Okay. So diagnosis, patient with anemia, peripheral smear and RBC indices you have to do. Spirocytes if it's there, workup for hemolytic anemia, then sickle cells and stuff like that. Only RBC abnormalities may be there, or pancytopenia will be there, which is megaloblastic anemia and aplastic anemia. All the cells are reduced. Okay, if only RBC abnormality is there, normocytic if it's there, then renal and hepatic disease impaired marrow response. Then macrocytic is there. If there is macrocytic megaloblastic, you have B12 and RBC folate deficiency. If it is non-megaloblastic, it is hypothyroidism, liver disease, myelodysplasia. Okay. If it is microcytic, then you do serum ferritin, iron ferritin. If it is low, that it is liver iron deficiency anemia. Then if it is normal, it is iron deficiency anemia, thalassemia, neutros test, hemolytic electrophoresis for HbA2. Thalassemia also can be there if the serum ferritin iron is normal, but if there is still deficiency. Iron deficiency anemia, clinical features. In majority of the cases, patient have no symptoms and entity is detected accidentally during examination. So clinical features, patient will be having fatigue or weakness, anorexia and indigestion, palpitation caused by ectopic beats, dyspnea or giddiness, swelling of the legs will be there. Ectopic beats will be there, palpitation, anorexia, indigestion, fatigue, weakness. So signs, you have pallor, glossitis, stomatitis, edema of the legs due to Hypoproteinemia associated preeclampsia, soft systolic murmur, mitral area, physiological mitral incompetence, crepitations at base of lungs due to congestion. Then you have degree of anemia, hemoglobin less than 10 gram percentage, RBC count less than 4 million per millimeter cube, packed cell volume less than 30%, PCV less than 30%. Types of anemia, you have peripheral blood smear you have to do, anisocytosis, poikilocytosis, and microcytic hypochromic anemia. Immunological indices, you have MCHC less than 30, MCV less than 75%, MCH less than 25 picogram. Blood analysis, you have serum iron less than 30 microgram per day. Total iron bearing capacity is more than 400 microgram per day. Serum transferrin saturation less than 10%. Serum ferritin less than 30 microgram per day. Stool causes of anemia, I have stool examination, detect helminthic, particularly hookworm infestation, urine examination for presence of protein, sugar and pus cells, X-ray chest you have for pulmonary tuberculosis, fractional test meal analysis of gastric juice, you have achlorhydria, fractional test meal analysis for gastric juice. Then osmotic fragility for hereditary spirocytosis. Then bone marrow study, it is indicated in cases not responding to therapy. Diagnose hypoplastic anemia, diagnose Kala-Azar by detecting LD bodies. Then in iron deficiency anemia, absence of hemocyanin granules when stained with Persian blue. Differential diagnosis may be infection, preeclampsia and hemoglobinopathies. Management is prophylactic treatment and curative treatment. Prophylactic treatment is birth spacing minimum 2 years, supplementary iron tablets, 200 mg of ferrous sulfate, 60 mg of elemental iron will be there, 1 mg folic acid will be there. Early detection, your hemoglobin estimation at first antenatal visit 30th week and 36th week. You have to do during 3 times. First antenatal visit, 30th week, 36th week. Okay. So supplementation 200 mg, a fifth of ferrous sulfate. Okay, FeSFO. 1 mg folic acid. Or a tenth of folic acid. But basically this should be having 60 mg of elemental iron, because this is the amount lost. Then curative therapy, you have oral therapy. Iron is absorbed in the ferrous form. Ferrous gluconate, ferrous fumarate, ferrous succinate and ferrous sulfate. So 325 mg ferrous sulfate, 60 mg of elemental iron will be there. I don't know. These both are two different values giving the same amount of elemental iron, but okay, just remember both of them. 1 tablet 3 times a day, 30 minutes before meal. Okay. The 1000th is folic acid. 10th is just 100. Okay. Then continued till blood picture becomes normal. And after that, maintenance dose of 1 mg is, I think this is 90. Yeah, 90 mg of elemental iron. Yeah, because if 200 is 60, then 325 will be 90, a third more. And the third, yeah, it makes sense. Okay, just divide by half and add it, and yeah, you will divide that also by half. So contraindication, intolerance will be there. Severe anemia in advanced pregnancy. You can give gluconate, fumarate, succinate, sulfate. Sulfate is the most common drug which is provided, and treatment is continued till blood pressure becomes normal. After that, maintenance was 1 tablet per day, at least 100 days. You have to remember. Then parental therapy, indication of parental therapy is contraindication of oral therapy, intolerance, severe anemia, patient not cooperative to take oral. So iron deficiency you have to calculate 4.4 times body weight times hemoglobin deficiency. This is one of the most important formula ever. Iron deficit is equal to 4.4 times body weight times hemoglobin deficient. Then preparations of iron, you have iron sucrose, iron dextrose, serum ferric glucuric complex. Route of administration, you have intramuscular 1 ml test dose, then 2 ml on alternate days. 2-inch needle debul, Z technique, so that upper outer quadrant of buttock you have to do. So small amount of air or saline before withdrawing the needle to prevent solution coming beneath the skin surface and causing staining. Then intravenous is more preferred because it's not painful. 0.5 ml, then it is 500 ml, 0.9 required amount of iron is mixed, then 10 drops per minute, initial 20 minutes, then it is increased to 40 drops per minute. Rigor, chest pain, hypotension, and you have to stop the infusion. Blood transfusion can be done if 1 unit raises by 0.8 to 1 gram percentage within 24 hours. Indicated is if there is severe anemia beyond 36 weeks of pregnancy, anemia due to active blood loss. If there is active blood loss and anemia, then refractory anemia that is not being cured even after we provide all the other drugs and all. Then thalassemia and pregnancy is not that important. It is a group of inherited blood disorders. Severe microcytic hypochromic anemia will be there. Absent or decreased production of alpha or beta globulin chain. So alpha thalassemia is absent or decreased production of globulin chain from deletion of a alpha globulin gene located on chromosome 16. Beta globulin from B globulin tritramers called HBH. Then fetus will be affected because fetal HB also requires alpha chain. So silent carrier may be there, alpha or AA, mild or mild microcytic. Then alpha thalassemia, if it is what do you say? If it is a dominant gene, if it is there, mild microcytic hypochromic will be there. Then if there is like one alpha is missing, then it is silent carrier. Here there is alpha is missing from one of the allele itself, so it is mild microcytic hypochromic, that is alpha thalassemia. HBH, so this is a moderate beta chains will be in excess, form an unstable tetramer called HBH. Multiple transfusions are required and moderate microcytic hypochromia may be there. Phe-type hydrops or HB Bart's disease is no amount of alpha chain only is there. This is no amount of alpha chain will be there. Excessive Y chain from fetal hemoglobin will be there. Marked anemia, hydrops, heart failure, pulmonary edema, death in early life. Beta thalassemia is absent or decreased production of beta globulin chain. A point mutation of it is due to point mutation of beta chain genes on chromosome 11. It was here it was deletion of also chromosome 16 and chromosome 11. CHR16 deletion, CHR11 mutation. Excessive alpha bind will bind to the red cell membrane and cause membrane damage. You have beta 0, which is absence of beta chain, beta plus decreased synthesis of beta chain. So severity will be depending on the same thing. So MCH, MCHC will be decreased. MCHC concentration will be normal, which is different from iron deficiency anemia, where all of them are low. Serum iron and total iron binding capacity will be normal or elevated. Serum hemoglobin electrophoresis, you'll find raised HbA2, alpha 2, and HbF. Then you have serum bilirubin raised about 2 to 3 mg percentage. Alpha 2, gamma 2 will be there, and HbF will be there. Pregnancy and thalassemia. Alpha thalassemia depends on the number of gene deletion. All 4 genes will lead to stillbirth, babies dying, so non-immune hydrops fetalis will be there. Sonographic measurement of cardiothoracic ratio at 13 to 15, 12 to 13 weeks of gestation identifies with features of non-immune hydrops fetalis. Non-immune hydrops fetalis. Non-immune hydroxyurea is HP Bart. Okay. Management. Women diagnosed with thalassemia should be offered preconception counseling, chorionic villi sampling done to see if fetus is affected, iron supplementation to be provided only if iron deficiency is present. Otherwise, hemochromatosis can occur. Parental iron is contraindicated. Thalassemia increases risk of neural tube defect. 4 mg folic acid supplementation to be done. Antepartum fetal testing, periodic fetal sonography to assess the fetal growth. No stress testing to evaluate the fetal well-being and detect hydroxyurea at a later gestational age. Heart disease in pregnancy, you have NYHA, functional classification of heart disease. So you have, first of all, grade 1, 2, 3 and 4. Grade 1 is no sign or symptoms of cardiac decompensation with physical activity. Class 2 is no symptoms at rest but minor limitation with activity. Type 3 is no symptoms at rest but marked limitation with activity. Type 4 is symptoms present at rest increasing with any physical activity. At rest, minor limitation in activity. At rest, major limitation in activity. Even at rest, not increasing with activity. No sign and no signs of cardiac decompensation. That is NYHA, functional classification of heart disease. Then you have NYHA, classification of maternal mortality associated with heart disease. Maternal mortality associated with heart disease. Okay, first we write NYHA grading. Minimal 0.0 to 1% is atrial septal defect, ventricular septal defect, patent ductus arteriosus, tetralogy of fallout which is corrected, and if mitral stenosis, NYHA 1 and 2, bioprosthetic valve. All of them have mild chances of mortality. 5 to 15% of chance of mortality is seen in mitral stenosis, NYHA 2 and 3, which is, this is moderate risk, NYHA 2, 3 and 4. Aortic stenosis is very much a moderate risk. Marfan syndrome with the corrected aorta, tetralogy of Fallot without corrected aorta, mitral stenosis with atrial fibrillation, if it is there. If there is atrial fibrillation, then it's moderate. Artificial valve, not a bioprosthetic valve. Artificial valve is a moderate risk of heart decompensation. Major mortality, which is 25 to 50%, is seen in pulmonary hypertension. Pulmonary hypertension is very much danger. Marfan's with aortic involvement, aortic coercitation with valvular involvement. This is the most important reasons for death. Pulmonary hypertension, Marfan's with non-aortic involvement and not corrected. Marfan's with aortic involvement, aortic coercitation with valvular involvement. So indications of heart disease, you have orthopnea, nocturnal cough, chest pain, hemoptysis and syncope. Okay. So signs, you have persistently dilated neck vein, increased JVP, cyanosis and clubbing, systolic murmur with thrill, diastolic murmur, cyanosis and clubbing will be there, systolic murmur with thrill will be there, diastolic murmur will be there, marked cardiomegaly will be there, arrhythmia, split S2. Okay. So admission to the hospital in cases of grade 1, 2 weeks prior to EDT you have to do. Grade 2 at 28th week only you have to be admitted. Grade 3 and 4, patient should be kept in hospital throughout the pregnancy if possible. Then absolute indication of therapeutic termination, like pulmonary hypertension, Eisenmenger syndrome, pulmonary veno-occlusive disease. Relative indication, Paris woman with grade 3 or 4, grade 1 or 2 with previous history of heart failure. Okay. Then we have Note on anticoagulants. Patient on warfarin should be discontinued as soon as pregnancy is diagnosed. Warfarin is replaced with heparin 5000 units twice daily. Subcutaneously up to 12th week it should be provided. Thin back, we have to thin back to warfarin and take some time daily up to 36 week. And after replacement with heparin up to 7 days postpartum you have to do. After that warfarin is still continued. Okay. So management you have antepartum left lateral rest you have to give. You always have to rest with the left side. So 2 mg sodium diet. Digitalis is as indicated. Diuretic as indicated. Avoid strenuous exercise. Avoid anemia. Fetal echogram if patient has congenital heart disease. Then intrapartum you have to aim for vaginal delivery. Patient should be allowed to go into spontaneous labor or induction with vaginal PGE2 may be done. In case it is safe in case of heart disease. Patient should be advised to be in proper position. No pushing. Epidural analgesia is given during labor for pain relief. Administer oxygen. Spontaneous bacterial subacute endocarditis prophylaxis. No, subacute bacterial endocarditis prophylaxis. I think so. SBE. Then anesthesia is given in epidural anesthesia. Prophylactic use of forceps of Walram to shorten the second stage of labor. Pulmonary artery catheter in case of 2 and 4. Postpartum, you have to check for intravascular overload due to sudden emptying of uterine venous sinuses after placental delivery. Then you have to deliver ergometrin. Methyl argonitine is contraindicated. They always worsen heart disease. Control the bleeding. Oxytocin can be given. Then breastfeeding not contraindicated unless there is a failure. Anticoagulant therapy is not a contraindication of breastfeeding. Okay. Cardiac indication of a cesarean delivery or contraindication of vaginal delivery if there is coarctation of aorta, aortic dissection, recent MI, aortic aneurysm or dilated aortic root more than 4 centimeter. Warfarin therapy within 2 weeks. Because fetus is also anticoagulated, vaginal delivery carries risk of fetal intracranial hemorrhage. Okay, so diabetes in pregnancy and HIV in pregnancy. Right, let's start. Pregnancy is a diabetogenic state because of insulin resistance will be there, because HPL will be formed. Increased production of cortisol, estrogen and progesterone is noticed, and increased destruction of insulin by kidneys and placenta is also noticed. There is increased lipolysis and altered gluconeogenesis. So risk factors: diabetes in first degree relatives, age more than 30 years, overweight, obesity before pregnancy, family history and previous history of gestational diabetes mellitus, history of more than 3 spontaneous abortions, history of stillbirth / unexplained neonatal death, history of delivery of large baby more than 4 kgs, glycosuria and impaired glucose metabolism, and history of congenital malformation will be there, polyhydramnios and recurrent monoliasis. All of these are risk factors of diabetes mellitus. Age more than 30 years. Diabetes in pregnancy may be of two types: gestational diabetes and overt diabetes will be there. One second. Okay, I'm back. Sorry. Gestational diabetes and over diabetes. So, gestational diabetes is normoglycemic female diabetes in pregnancy due to insulin resistance. Insulin resistance diabetes. Insulin resistance in early pregnancy, maximum at 23 to 28 weeks due to effort of HPL. Then, high blood sugar leads to formation of free radicals, fetal malformation. Organogenesis is complete by 24 weeks of gestation. Gestational diabetes mellitus occurs around 24 weeks of gestation, does not lead to congenital malformation. So, if it is more than 24 weeks, it will not lead to congenital malformation. Less than, okay, so high blood sugar leads to formation of free radical leading to fetal malformation, damage to fetus. Maximum at 24 and 28 weeks due to effects of HPL. Normoglycemic female depend and develops diabetes in pregnancy due to insulin resistance. Normoglycemic female develops diabetes in pregnancy due to insulin resistance. Okay. Overt diabetes is patients have diabetes mellitus type 1 and type 2. You have hyperglycemic female becomes pregnant if it is there. Then you switch to oral OHA therapy to insulin. OHA can cross the placenta. What is OHA? Oral. Okay, but basically it will lead to congenital malformation because patient has high glucose since day one. And they already have diabetes, but and they're then pregnant. Gestational diabetes is pregnancy happens, then they become pregnant. Okay, due to insulin resistance because pregnancy is a diabetogenic state because it's a HPL, human placental lactogen, cortisol, estrogen, progesterone, and destruction of insulin by kidneys and placenta will be there. Increased lipolysis will be there, altered gluconeogenesis. Okay, American Diabetes Associated as criteria for diagnosis of overt diabetes during pregnancy. Random plasma glucose is more than 200 mg per deciliter with classical signs of diabetes. Fasting blood glucose more than 125 ml of per deciliter. HbA1c is more than 6.5. Two or more abnormal values on 100 gram OGTT or 75 gram OGTT also may be there. And effect of diabetes on pregnancy. During pregnancy, you will have abortion, preeclampsia, polyhydramnios, preterm delivery, UTI, and vaginal candidiasis, and ketoacidosis. During labor, you will have prolonged labor, shoulder dystocia, increased chance of LSCS, and postpartum hemorrhage. During prepurum, you have prepural sepsis, wound infection, and lactation failure. Complications of diabetes in fetus, you will have hyperglycemia, macrosomia, shoulder dystocia, abnormals or IUD, intrauterine death, and abortions or IUD, and congenital malformation. So in that congenital malformation in cardiac, you have ASD, VSD, TGV. Transposition of great vessel is the most specific CVS anomaly in diabetes mellitus, and HOCM, hypertrophic obstructive cardiomyopathy. CNS, you'll have anencephaly and spina bifida. Anencephaly, spina bifida will be there. Skeletal will cause regression syndrome, which is sacral agenesis. Most specific anomaly in diabetes mellitus. Caudal regression, sacral agenesis. Then in gut you have absent kidneys, polycystic kidney, double ureter, tracheoesophageal fistula, imperforatinus, bowel atresia, left colon syndrome, and delayed lung maturity will be seen. Then neonatal you'll find prematurity, respiratory distress syndrome, hypoglycemia, hypocalcemia, hypomagnesemia, hypokalemia, hyperviscosity syndrome, hyperbilirubin, and polycythemia, obesity, and future diabetes will be there. Those are the complication. Then screening, it is performed in all pregnant women 24 to 28 weeks of gestation. 24 to 28 weeks of gestation. Patient with risk factor screening is done first by a prenatal visit, then 28 weeks if there are risk factors. Then 1 hour for 50 gram OGTT. If it is less, it is normal. If it is more, then 3 hour 100 gram FGCT and fasting blood sugar is to be done. 3 hour and more than 200 and more than 70 95 respectively, gestational diabetes is diagnosed. So first you have 140 for 50 gram OGTT, then you have 200 for 100 gram OGTT and 95 mg per deciliter in GDM. Okay. And then normal values, fasting blood sugar less than 95 mg per deciliter, like OGTT, all these values can be there. Then one value is abnormal, impaired glucose tolerance. If any one value is abnormal, if more than two values are abnormal, it is gestational diabetes mellitus. If it is more than 125, overt diabetes is diagnosed. 100 gram glucose load should not be there. Then management, antepartum, you have antepartum glucose management. American Diabetes Association diet. 80% of patients with gestational diabetes mellitus can maintain glucose control with diet therapy. Okay, diet therapy, you have to educate complex carbohydrates they have to eat. Women, home blood glucose monitoring. Four times a day with target values should be there. 50 years less than. You just have to monitor them, and insulin can be provided at home. Total insulin level is weight times 0.8 in first trimester, 1 in second trimester, and 1.2 in third trimester. 2/3 in morning, 1/3 in evening. Okay, large molecule does not cross placenta, and OHA is contraindicated. I just want to check what OHA is. I'll check it 1 second after I finish everything. Then abnormal screening, you have quadruple marker test from 16 to 18 weeks for neonatal Down syndrome, ETD. Targeted ultrasonogram at 16 to 24 weeks for structural abnormalities. Fetal echogram for congenital heart diseases. Fetal growth multi-sonogram and biophysical assay. Sonograms for fetal microsomia or urea. Field surveillance you can do shuttling weekly NSTs, non-stress tests, and acid fast indices at 28 weeks. Intrapartum management, you have amniotic fluid lecithin spironolactone ratio of 2.5 and presence of phosphatidylglycerol ensures fetal lung maturity. So you maintain maternal glucose level between 80 to 100, and LSCS performed in case of maternal diabetes induced fetal complication. You have to provide insulin drip. Then postpartum management, you have postpartum hemorrhage, which is uterine or atony related over distended uterus and all. It will be there. You have to prevent hypoglycemia. Insulin transfusion stopped because insulin resistance decreases with rapid fall in HPL level after the delivery of placenta. Then HIV in pregnancy, mode of transmission is infected body secretion, sharing of needles, intercourse with infected partner, periplacental transfusion. Risk factors, yeah, maternal high plasma viral load, low CDC4 count, coexisting STDs and opportunistic infection, prolonged rupture of membranes, chorioamnionitis, vaginal delivery, and breastfeeding. All of this will lead to increased perinatal transmission. So fetal infection, placental transmission or vertical transmission will be there. Contact with infected genital secretions during delivery, and maternal aziothymin (AZD) prophylaxis. ACD you can never have. Elective cesarean. Neonatal infection. HIV positive women will have positive HIV test from transplacental progressive IgG passage. HIV infected breast milk can parentally transmit the disease to the newborn. Breast milk is contraindicated. HIV to AIDS in infants is more rapid than in adults because they have lesser immunity and all stuff like that. IgG in transplacental passive IgG passage. Okay. Antiviral prophylaxis, you give triple drug therapy, 2 NRTI with 1 NNRTI or protease inhibitor, xylovidine, lamivudine, indanivir. Okay. And AZT, azithromycin. Planned delivery at 35 weeks. Avoid amniotomy. Do not use scalp electrodes. Avoid forceps or vacuum extractor. Use gentle neonatal resuscitation. Where allowed is more cesarean section. Breastfeeding avoided. Universal precaution. Careful attention to handling all body fluids. Treatment highly active HAART. Triple chemotherapy. It should be continued throughout pregnancy, labor, and postpartum. Suppress viral multiplication. Decrease the risk. Okay. Eflivirance is avoided due to its teratogenic. Prophylactic antibiotics in case of opportunistic infection, pneumocystis, pneumonia. None of these are important. Acute pain, ovarian torsion, red degeneration, pneumonitis, cystitis, hepatitis, ulcer, acute appendicitis, perforation, obstruction, organs, cystitis. Okay. Obstetrical H-mole, abortion, polyhydramnios, abruptio placenta, preterm labor pain, uterine rupture, eclampsia, syndrome, and uterine torsion. Okay. Management of carcinoma cervix. Unsatisfactory smear, repeat. Normal is repeat after 3 years. Dyskaryocytic, mild, repeat after 6 months. Moderate and severe, you do colonoscopy. If it is not available, if it is available, you do direct biopsy. If it's not available, you have to do biopsy with Chiller's test and cone biopsy to avoid bleeding abortion or preterm labor. Cone biopsy is avoided because cervical components will be decreased. If it is cervical intraepithelial 1 to 3, repeat every 6 with smear and colposcopy, re-evaluate 6 weeks postpartum. If it is micro-invasive less than 3, therapeutic conization and postpartum evaluation you have to do. If it is more than 3 mm, you have to consult the patient on gestational age, tumor, metastatic evaluation and her desire for the baby. You have to do radical hysterectomy, neonatal chemotherapy before surgery or irradiation, and chemotherapy and radiation, external beam and brachytherapy should be done. And that is medical and surgical disorders affecting pregnancy. Okay, page number 83. I'll see 83 to 107, which is around 24 pages, and this another 15 pages. Around 2 more hours it'll take. I've been streaming for 1 hour. Okay, I'll finish this. I'll come back. I'll finish preterm labor, complicated pregnancy, contracted pelvis, and abnormal uterine auction. Finish all of them. Obstructed labor and dystocia due to fetal anomalies. Maybe this one also I'll do. Injuries to birth canal I have to do. 124. 1 second. What is 124? Oh, PPH. Okay, this is kind of easy. Okay. Retained placenta and uterine inversion will be a little bit difficult to remember. Okay. And try and add this also to it. Okay, I'll start the stream after a bit. My voice is kind of hurting, and I had a screensaver on the entire time I've been teaching. Yep, it's one of those streams. Damn it.